My name is Dr. Robert Naparstek. I'll serve as your moderator today for this very important presentation put on by the Center for Reconciliation. Our mission is to foster racial reconciliation and justice by confronting the legacy and enduring impact of slavery. Today, we have a panel of 4 distinguished people to present Racism as a Public Health Crisis, Race and COVID-19 in Rhode Island. I'll ask each panelist to present for approximately 15 minutes, and then after all 4 speak, we'll follow up with a question and answer panel discussion. Our panelists today are Dr. Pablo Rodriguez, Mr. David Casey, Dr. Michael Fine, and Dr. Marie Gazelle. Please send any question you have to me on the private chat, and I'll collate and organize them for our Q&A session after all 4 panelists speak. Structural racism is the ultimate pre-existing condition. The seeds of slavery have given root to it in such forms as the inequities of segregated and crowded housing, employment categories, access to healthcare and good nutrition, as well as outright discrimination. This pandemic has illuminated what has always been right in front of our eyes. It's always in plain sight if we choose to see it. The kidnapping and enslavement of human beings who built this country manifests today as what we like to call social determinants of health. They've devastated communities across the United States. We doctors always want to investigate and uncover the causes of illness. Along with other environmental toxins, we have to always include the exposures to racism if we're to understand the causes of disease more thoroughly and attempt to heal them. In fact, a growing body of medical literature on healthcare disparities shows how discrimination and racism promote things such as cardiovascular diseases, accelerating aging, and impeding renal function. This is the burden for Black and other communities of color. We gather today now as Rhode Islanders and others, welcome all of you from other states and places. We hold ourselves and our country accountable to its founding ideals and principles. Those are life and breath, liberty, and the pursuit of happiness for everyone. At this time, I'm honored to introduce our first panelist, Dr. Pablo Rodriguez. He's an associate professor of OBGYN at Warren Alpert Medical School of Brown University. He was the president and CEO of Women's Care, a multi-specialty group in Southern New England, and is former medical director of Planned Parenthood of Rhode Island. He's also been a board member of the Alan Guttmacher Institute and the National Latina Institute for Reproductive Health. He co-founded the Rhode Island Latino Political Action Committee and Latino Public Radio, where he hosted a daily radio show in Spanish on healthcare issues, for which he was recently awarded the Metcalf Media Award. He currently hosts a health-themed webcast called Nuestra Salud and a news analysis show called Cirugía Política, both on roadinforma.com. He also hosts a daily talk show on La Mega 94.9 FM. Dr. Rodriguez, if you please.
Thank you very much, Robert. Pleasure to be here, and thank you for this invitation. This topic is very close to my heart as a physician, as a human being, and as a member of this community. And I hope that this horrible situation becomes an opportunity, and I think it will, for us to really start working on the causes and the disparities that have created an epidemic that has largely affected people of color. I have some slides that I'd like to share with you, so I am going to just share my screen and start my presentation. The epidemic obviously has affected people of color more than the rest of the community. And the way we compare that is by using, numbers per 10,000 people. And that's how you can see the burden of disease in communities of color. As you can see, with by the slide, 73 per 10,000 people of Latino origin are infected, and 62 African Americans, Blacks are impacted compared to 23 in the white community. Even though the white community is much larger and you see bigger gross numbers, the rate is an important way to, to compare populations. It's really essential, for us to understand that the media has sometimes, mixed the messages around this epidemic, talking about older versus younger people, which in reality, when talking about mortality, that's an actual fact. But when you look at the age distribution of cases, both in the Black and the Latino communities, you'll see that compared again per 10,000 people in terms of the white community, even in those ages where we see a higher mortality because of age, we still see more cases in the Black and the Latino communities. And people tend to think, well, this might not be the same, all over the country. And you know what? It is exactly the same all over the country. And this is, a graph that, I really, when I found it, I said, this is really, really very helpful, because it gives us an idea of how, sometimes we confuse poverty and other issues with COVID, when in reality, the concentration of people of color is what raises the rate of a community. And you can see in this chart, the communities that have less than 30% people of color, regardless of income, are 7 per 100,000. When you look at counties that have 40 to 50% people of color, that goes up all the way to 18. And this is on a 7-day average. So this is, a clear evidence that this epidemic is raging in communities of color. When you look at the rate again, in terms of cases compared to the white population, Latino and Black communities have 2 to 3 times the rate of white cases. And in terms of hospitalizations, it gets even more precarious, where Latinos and African Americans have 4 to 5 times the rate of hospitalizations than the white population. And this is very important because, again, when we look at gross numbers or percentages, that gives you a very confusing picture of what the reality of this disease is in people of color, in communities of color. Here in Rhode Island, numbers speak for themselves as well. In terms of cases, Latinos represent 46% of all cases. So these are gross numbers. Whites, 36%, African Americans, 12%. But when you look at their percentage of the population, then you realize how bad the epidemic here is in Rhode Island, with Latinos being only 16, 17% of the population, and African Americans only being 6% of the population. When you look at hospitalizations, again, if you look at percentages, you're going to see more whites being hospitalized, but that is because they are more members of that group in the community. And where you see the most difference is in fatalities. And this is because the epidemic in the white community has been largely in nursing homes and people of more advanced age. And the Latino and the African American communities are much younger. In this chart, you can see that the green color is the ages between 20 and 39 years of age. That's where the majority of cases are in the Latino and the African American community, compared to only 21% of people, of white people between 20 and 39. So the young nature of the both Latino and African American communities affords some protection, simply because they have less chronic disease and less infirmity. And this chart also is very, very helpful in understanding the comparison of the share of the population with the share of the cases. So Latinos, 16% of the population, 44% of the cases, 6% of the population for African Americans, 13% of the cases, 71% of the population are white, and yet they represent 39% of the cases. So if you didn't look at any of that and only looked at places, at cities, what you will find again is you know where people of color live in Rhode Island by the proportion of cases per 100,000 population. And you can see Central Falls with a rate of 4,762 cases per 100,000 population. That is higher than the highest level of infection that we saw in the city of New York. And it compares to areas like Chelsea, Massachusetts, that represent the same, same type of population with an overwhelming Latino population. When you look at the number of tests that are being performed and the percentage of tests that are positive, this is an important measure for the progression and the activity of an epidemic. And what you can see, and what the World Health Organization recommends for a pandemic or an epidemic that is under control is under 5% of all tests being positive. Well, you can see Central Falls, Providence, North Providence, and Pawtucket, areas with large concentration of people of color, have rates of 23, 20, 15%. And some of the areas that are largely white don't even show up in this chart. I couldn't fit them in the graphic. One of the things that was really interesting and puzzling for me when we started looking at the beginning of the pandemic is that I thought that the reason Latinos were being overrepresented was because of an overrepresentation in working in nursing homes, hospitals, orderlies, and in the cleaning services of the hospitals. And lo and behold, the numbers do not reflect that. Only 9% of Latinos work in the healthcare field. So that points to a different place of infection. And that tends to be the area of service, people that need to work, people that go to factories, people that work in meat packing plants, people that work in locations that are completely and absolutely aggregated and congregated in such a way that they can have social distances. For African Americans, however, 47% of the positive individuals for COVID do work in the healthcare field. So why is this happening in communities of color? If I can leave you with a single message today, is that it is not because of obesity and chronic conditions. You know, this is something that I've seen in the media repeated over and over again. And yes, obesity and chronic conditions do make people more susceptible to complications once you become infected, but you're not going to become infected simply because you are obese and have chronic conditions. If you are able to social distance, if you are able to work from home, if you are able to live in a community or in a circumstance where you are not living with, 10, 15, 20 other people, then you will not become infected. And that's what's happened with Latinos specifically. They are the essential workers. They are the ones working in healthcare, in meat packing, in grocery stores, in factories. They don't have sick leave. They can't stay home, and also need to use public transportation, many of them, or transportation that is a car with that is set up for 4 people but carries 6 or 8 in order to go to work. So unable to distance from one another. And a great example of this is the meat packers or industry has been especially devastated by COVID. And of all the positive COVID for meat packers in the country, 60% of them are Latino. the racial housing segregation that exists in Rhode Island and in many communities is really, really huge. And so what you have in areas like Central Falls is multi-deckers, houses next to each other, multi-generational housing where you have 2-3 generations living under the same roof, unable to distance each other. And once one person becomes infected, then the entire family becomes infected. On top of that, you can add then the immigration status of people, the fear of deportation, the inability of people that are undocumented to be able to stay home, number one, because they don't qualify for any benefits. And number two, the fear of even accessing healthcare or going to one of the testing sites. And I still remember when the first testing site was set up by CVS that was being manned by National Guard people. My first thought was like, those are people with military uniforms. It's going to be very, very tough for undocumented people to feel confident that they're going to go to a government facility with people uniformed to have a test. So that fear of deportation, the lack of access to healthcare for many of them makes it very, very difficult. And finally, we can never forget the correctional system, the jails, the homeless shelters, the detention centers, where people of color are completely overrepresented. And when the epidemic first started, that was the first place where I interviewed on my show, the director of the ACI, and I said, you guys are going to have to be very, very serious about infection control, because you guys are going to be the place where this is going to spread much, much quickly. And we've seen it all throughout the country, where jails and detention centers, immigration centers are completely and absolutely overwhelmed with infection. So, all these things are as a result of inequities that have taken many, many years to get us to where we are today. And sometimes, I don't like to use the word racism simply because people become so defensive. Oh, I'm not a racist. My company is not a racist, but you have racist attitudes. You have racist ideas and policies, even if you don't know you do. And I think that the majority of situations where racism is manifested is as a result of ignorance, as a result of neglect, as a result of people not having the experiences that are necessary to understand what it is to be a racially conscious and a just and equal place of work. This reminds me of the words of James Baldwin when he said that color is not a personal nor a I have the phrase right here. Color is not a human or a personal reality. It is a political reality. And that is what we need to understand, that it is the will of our political system to be able to work on these inequities, to be able to create a society where people can have access to healthcare, where people can live in circumstances that do not put them in harm's way in terms of this epidemic. The only way we are all going to be protected, the only way that we are all going to be able to move forward as a society. Thank you.
Pablo, that was terrific. And thank you for all the data as well, because, some people don't want to believe what you're saying, and the numbers are pretty clear. So thank you. Next, I'd like to introduce Mr. David Casey. David is Vice President of Workforce Strategies and Chief Diversity Officer for CVS Health. In this leadership role, David is accountable for strategic diversity management, affirmative action, and workforce initiatives. Previously, David served as the Vice President of Workplace Culture and Chief Diversity Officer at Anthem, at the time the nation's largest health insurer by membership. David is also an 8-year veteran of the Marine Corps, having served in Operation Desert Storm. Active in the community, David has served and currently serves in an advisory and board of director capacity for several national and local organizations, including the American Lung Association, and here in Rhode Island, the Greater Providence Chamber of Commerce, Skills for Rhode Island's Future, and Year Up Providence. Through his work and expertise, David has earned several professional service accolades, including recognition by Black Enterprise magazine as a top diversity executive. During his tenure at CVS Health, the company has earned a place on major public rankings, including Diversity Inc.'s top 50 companies for diversity, and Fortune magazine's annual list of the world's most admired companies, a leading report card on corporate reputation. With more than 18 years of experience, David is recognized as an expert in the field of strategic diversity management and has been published or cited in publications such as Forbes, Wall Street Journal, New York Times, among many, many others. So I present Mr. David Casey. Take it away, David.
Thank you for that intro, Robert. I always hate those because it feels like somebody's reading your obituary. So I do appreciate that, though. Thank you very much. I come to you all today, and thank you all for being on the Zoom meeting today. I come to you from Indianapolis, Indiana, after having lived in Rhode Island for 8 years, which I thoroughly enjoyed. My wife and I, about 3 years ago, moved back to Indianapolis to help care for her parents. So it is nice to be back home, but I do miss a lot of things about Rhode Island, including Dell's Lemonade, which Robert promised to give me more of at some point in the near future. So like all of you on the call today, I'm pretty sure that we all wish that we were not here having this conversation, but here we are. You know, I've been doing this work for 20 years now, and part of the paradox of my role as a chief diversity officer is that I am happy that the conversation seems to has escalated and is getting more traction than I think it ever has, at least in my professional experience. But you also wonder, why did it take till now to get us there? You know, these are not new conversations. As a matter of fact, many of these conversations are the same ones that we've been having since I got into this field, 20 years ago. So it's a bit of a paradox for me as a diversity practitioner at this point. And I find it interesting. I think Dr. Rodriguez hit on a number of points really well. And one point that's interesting is how people get so defensive around even just having a conversation about racism or being called out and acknowledged for acts that may be racist, or policies that may be racist, or beliefs that may be racist. So one of the books that I've read recently, if you haven't read it, you may want to take a look at it, that I think is a great primer for having these conversations with individuals to maybe let down their guard a little bit about understanding how they may be engaged in racist behavior. But the name of the book is actually Racism Without Racist. And if you haven't read that, I would encourage you to do so, because it really goes into detail around, again, inherently, you may not be someone who believes that, your particular race or identity is supremacist, but you are susceptible to believing in racist policies and enacting racist policies and beliefs. I got a view into some current thinking around race when back in March, I posted some data on LinkedIn. At that time, we were starting to really see and publicize data around the Black and African American community related to COVID-19. And the data was showing that, Blacks and African Americans were dying at about 2.5 times the rate of the white population. And I posted a link to that data point on LinkedIn. And I had someone respond, I had a couple people respond in short order with, now we're in a global pandemic. Now is not the time to have conversations about race. And I thought to myself, that is extremely odd. It's not that I didn't expect that response, because we all know how social media works. But I thought it was an odd response because we had up to that point a lot of conversation about the impact of COVID-19 on people over the age of 50 or 60. And no one seemed to dispute that. No one seemed to say now is not the time to talk about our older population. People kind of said, okay, well, we really need to understand that. We really need to make sure we're protecting, older individuals who are in the population. to mitigate the risk of COVID-19. So didn't see any pushback arguments on that. But as soon as I brought up a data point, not an opinion, not an editorial, but a data point that showed the mortality rate of 2.5 times the white population, immediately got pushed back. So why is that? You know, matters of race go back to our country's origin. As a matter of fact, it's been said by some that you think about the experience of African Americans in this country, and some have said that slavery is the country's original sin. And I would say it's not just the country's original sin, it's the country's very origin. You know, this country was built on slavery. And when you think about the experience and the timeline, I've had a number of people say, David, why now? Why is the Black community in particular, what was that powder keg, and what was the spark that lit that powder keg? Let's think about the Black experience, or the African American experience in this country, beginning in 1619, you know, with being enslaved Americans. So we weren't technically freed, and I say technically because we all know how things actually played out in practice, but by law, we were technically freed from slavery in 1865. And again, I say freed because we all know the impact the 13th Amendment had on that practice, really just another way to legalize the practice of slavery. So from 1619 to 1865, we're enslaved. Then we go all the way from 1865 to not having earnest conversations and putting earnest practices and laws in place around civil rights until the 1960s. And we are still litigating and adjudicating what we put in place in the 1960s in the year 2020. So I hear frequently people make comments like, slavery was a long time ago, get over it. You know, I didn't own slaves, you know, what's the problem? Why are you trying to make me feel guilty? The vestiges of that history have not gone anywhere. And I think some of the spark that served as the catalyst for the intensity and the volume and the sense of outrage and exhaustion that you're feeling now is not having been able to have that conversation for 401 years. I'm also starting to see, after about 3 or 4 weeks of this level of intensity after George Floyd's killing, that there's a bit of what I call diversity fatigue. And I think it's coming in a couple different ways. When it's coming in the form of exhaustion, in large part from Blacks and African Americans, because while we have wanted to have this conversation, we don't want to carry the burden of having to educate people on that 401 year history. You know, we want people to go out and Google for themselves, read for themselves. We can help, you know, amplify that understanding. We can help enhance that understanding, but we don't want to take on the burden of being the ones to do that education. So there's a sense of exhaustion coming in that form. The other exhaustion that I'm really worried about is I'm starting to see some and hear some narrative around, oh my gosh, it's been 3-4 weeks already. Can't we just move on? You know, I heard a gentleman say a couple of weeks ago that the system is designed to absorb temporary outrage. And what he meant by that was, you know, George Floyd, Ahmaud Arbery, Breonna Taylor, they weren't new. Trayvon Martin, Philando Castile. I mean, I don't even have time to rattle off all the names. These aren't new situations. But what has happened historically, and more times than not, we get enraged, we get outraged, we protest, you know, and we come up with hashtags and they trend on Twitter for a couple of days, and then we move on to the next news cycle. And I think his caution with that statement was that the system is designed to absorb temporary outrage. I think that's a cautionary narrative for us to pay attention to right now. Is this going to be another hashtag moment that we will move beyond when something more sexy or exciting pops up in the news cycle? So, you know, we can articulate very factual points that deal with race or ethnicity in this country. And whether it's fact or not, people get defensive. They have an editorial. They don't want to have a grown-up conversation about that. Beyonce was given credit for this quote. It was on the internet, so if it's on the internet, it must be true. I'm not really sure if she said it or not, but she's been given attribution for for saying that racism is so American that when I protest it, people think I'm protesting America. And Dr. Rodriguez quoted James Baldwin, and I'm going to quote a little bit of Baldwin myself. James Baldwin had a little bit of a different take on that. And he said, "I love America more than any other country in the world. And exactly for this reason, I insist on criticizing her perpetually." So, you know, when I criticize America, when I criticize things that aren't being done the way they should be, or when I see discrimination being perpetuated, it's not that I hate America. You know, Robert mentioned, I served 8 years in the military. I have a strong sense of pride for this country. It's all I know. I've never lived in another country. I have very close connections to where my origins are, so I understand that, but I've never lived in another country. I love America. And it's exhausting to hear people push back on that when they hear you criticize this country to try to make it better, that you're being un-American. I think that's another reason why we can't have productive conversation, because racism is so tied to America's identity. When you attack racism, people think that you're attacking America, and that's not the case. So, you know, as Dr. Rodriguez said, I'm not going to belabor the great points that he already made. We understand now that COVID-19 did not create disparities and inequalities, but they certainly uncovered them, and they exacerbated those inequalities. And again, Dr. Rodriguez spoke eloquently to some of the mitigating factors around that. One being essential workers. And you think about the biggest sectors of essential workers: food and agriculture, healthcare, and not just the providers, but the folks who are cleaning the rooms, the folks who are transporting sick patients, industrial, commercial, residential facilities and services, government and community-based organizations are filled by people of color. And in some markets like New York City, they're 75% of the essential workers. Disparities in housing, transportation. These things show up not just in racist rhetoric, they show up in policies that seem benign on the surface, but have a very negative impact. And I'll give you a quick example. One is when you think about how testing rolled out for COVID-19, it was primarily focused on drive-through testing. And I understand some of the reasons why. There was a need to protect healthcare workers. There was an ability to get a lot of people through testing sites fairly quickly, so I get that. But when you understood the impact of COVID-19's infection rate and mortality rate, who that was impacting, you have to take a step back and think, okay, well, how much of that population does not have access to a personal vehicle? So we're rolling out testing for a deadly global pandemic, but a lot of folks who are being the most negatively impacted aren't going to have access to that testing because they don't have access to a personal vehicle. So we took a step back at CVS, and one of the things we did was partnered with HHS, and we rolled out what we're calling community-based testing sites. And in partnership with Dr. Fine and Rhode Island College, the University of Rhode Island, and many other collaborators on the community site that we have on Dexter Street in Central Falls, we have a community-based site that allows people and affords people the ability to walk in and walk up to get tested. We've done, since we launched that site, we've done over 1,200 tests at that site. And I will tell you that one thing that I'm hoping someone will help me uncover on this Zoom call today, because I don't know the answer, but I'll tell you some of the interesting data points that we're starting to see nationally. And I think we're also seeing that they're play out there in Rhode Island, is that we talked about the disparate impact in the Black and Brown community. So we are seeing Blacks and African Americans come out at about half the rate to get tested than Hispanics and Latinos. And I don't know why that is. Even as recently as July the 4th, my wife and I drove around town in Indianapolis, and we drove through a couple of predominantly Black neighborhoods. And we were sitting there just completely perplexed because we were like, did we miss the memo? Did somebody declare COVID-19 is over? Because we saw so many cookouts, so many gatherings, 10, 20 cars, parked out front, people congregating in front and backyards, not a mask in sight. So I don't know what's driving some of that behavior. I don't know if it's a lack of information. I don't know if it's where the majority of our populations are younger, so young people aren't as concerned about getting it. I don't know if people are just resigned to, if I get it, I get it, I'm going to get over it and I'll move on. It's nothing more than the flu. It might be all of the above, but I don't know what factors are keeping Black and African American community members from coming out and getting tested when the data shows what the disparate impact is. So I'm hoping that through our dialogue today, someone else can even shed some light on that for me. And we are seeing twice the positive test rates come back in the Hispanic and Latino community than we're seeing of those who are getting tested. So again, I hope that we can continue to get some insights into what's driving that. So I'm going to wrap up, Robert, with my intro remarks with going back to, again, this broader context of where we are as a society. We at CVS, we do think about diversity globally. And when I say globally, I mean all demographics. We look at all racial demographics, all ethnicities. We look at military experience, people with disabilities, the older workforce, the whole 9 yards. I've got a team of people focused on all of that. But one thing that we have declared and one thing that we have to be in tune to is that our workforce is only made up of the communities from which they come. And right now we are having a priority conversation about the Black experience in the country. It's not at the expense of all of the demographics we have to pay attention to, but it is a priority conversation given what's happened, especially recently. And we made some commitments. Some of you may have read about those. You may have seen some of the commitments that we started communicating publicly yesterday. And I will tell you that one thing I'm encouraged about is that at CVS, the things we need to do are not new to us. What is new to us as a company and what's new to us as a society is holding ourselves to a much higher level of accountability for actually delivering on the things we know we need to do. And I would say that's where we are as a society as well, not just the company. A large chunk of the financial investment that we announced yesterday and the day before is going to be focused on affordable housing. We all know and have heard that your zip code is just as much of an impact or influence on your health as your genetic code. So we are going to be investing significantly in affordable housing. We are going to be investing significantly into bringing healthcare to the community. Even with 10,000 stores across the country, we still know that, and 75% of the country has access to a CVS store within 3 or 4 miles. But that's still not good enough. We want to make sure that we can get deeper into communities. So we're going to be enhancing some of our mobile capability to bring healthcare into communities as well. And I was very encouraged to see, and Robert, I'll finish with this. I was very encouraged to see that one of our attendees today, Carol Robinson, I'm going to call you out because I saw one of your comments earlier as people started coming into the chat that I believe in Michigan, your governor announced today that implicit bias training is now going to be mandatory for any provider who renews their license. That's encouraging. One of the things that we're investing in at CVS Health as well is bringing cultural competency training and implicit bias training to providers. So we're not only going to be doing that internally as a company, as a mandatory training, we're also going to be helping to bring that to our communities. So I was very encouraged about what Michigan did today, and I certainly hope to see other states follow. So Robert, with that, I'm going to stop. Probably got a warning. I wasn't looking at my chat. I want to make sure I'm not going over time, but I will stop with that, and thank you all again.
All right. Thanks, David. That was terrific. I especially appreciate you bringing us back to 1619 in terms of the big view and why we're still here, 400 years later is obviously terrible. But thank you, and thank you for your work as well. You engendered some questions too that we'll come back to in the Q&A portion. Next, I'm honored to introduce Dr. Michael Fine. He's an author, community organizer, and family physician. He serves as Chief Health Strategist for the City of Central Falls and Health Liaison for the City of Pawtucket in Rhode Island. As many of you know, Dr. Fine served in the cabinet of Governor Lincoln Chafee as Director of the Rhode Island Department of Health from 2011 to 2015. He oversaw a broad range of public health programs and services. Dr. Fine also is an author of some pretty wonderful books. The Healthcare Revolt is an expose, manifesto, and playbook that exposes the failure of the healthcare market to deliver health and plans a movement to build a healthcare system that the United States needs. He also wrote a novel called Abundance about two young Americans in the Liberian civil wars of 1998. And is also an author of a book called The Nature of Health, a study of healthcare services, human rights, society, technology, and industry. What many people don't know about Dr. Fine is that when he was younger, he had early experience as a printer, a metal worker, a New York City cab driver, and a Vista volunteer and community organizer in the South Bronx. As a National Health Services Corps scholar in the mid-'80s, Dr. Fine worked for 3 years in rural Tennessee, in the 5th poorest county in America. In that community, with an illiteracy rate of 60%, he experienced the strong link between education and health, income and health, and healthcare with local economic development. I introduce Dr. Fine.
Thank you, Robert, and thanks to David and Pablo for their excellent presentations. Thank you all for being here and for the work you're doing and thinking through as we kind of rethink the American experience, or try to get it right this time after 400 years of failure to get it right. I want to start by taking up from David and about the hashtag moment, because I'm particularly worried that energy is turning into lip service too quickly. And we need to really keep our pedal to the metal and keep our eyes on the prize if we're going to get any kind of fundamental improvement at all. And I'm honored to be able to talk about a hashtag moment in some ways from the perspective of public health, because public health has the opportunity to take us beyond that hashtag moment and to create a new kind of accountability. Public health gives us the opportunity to bear witness, to look at the numbers and what's really going on, and understand how societies are organized, and to compare society to society and see who's doing better and why they're doing better, and who's doing worse and why they're not doing as well as others. So I think I will start by mentioning some numbers, not as many as Pablo's. Pablo got all the good ones, or at least for COVID-19. I'm going to talk more generally and briefly about life expectancy in the United States. The average life expectancy for people of Asian descent is 87 years. The average life expectancy for African Americans in the United States is 75 years, 12 years difference. And the life expectancy difference between whites and African Americans in the United States has been 5 years for 20 or 30 years, basically as long as I can remember. A similar measure that we use in public health is infant mortality. Infant mortality really reflects the extent to which we do a good job taking care of our young people. When women are pregnant, they are the people who we ought to take the best care of, and how we take care of them, and the social situations in which they live, and the social situations into which babies are born reflects a significant amount about who we are and what's going to happen in terms of the ability of children to survive their first year. For as long as I can remember, the infant mortality rate in the United States for African Americans has been about 12 per thousand live births, that or higher. The infant mortality rate for whites in the United States is about 4.9 per thousand live births, and for Asians is 3.6 per thousand live births. The best achievable income mortality rates in the world are under 2 per thousand live births. So we as a nation have accepted an infant mortality rate that's 2.5 the best achievable rates. And I think we should be ashamed, because it reflects the way in which we do not take care of children and we do not take care of young mothers. And if that wasn't bad enough, the infant mortality rate for African Americans in the United States is 6 times the best achievable rate. And I think you have to sort of we have to look at ourselves and ask a very simple question, which is, who are we? And how did this happen? It happens through 3 pathways. The most powerful pathway is the pathway of what's sometimes called structural racism. First, differences and disparities in education and educational opportunities, which have a significant impact on the job opportunities and income that people will have throughout their lives. Second, disparities in housing, the extent to which people live in safe and healthy housing or do not and cannot. And we definitely saw this during COVID-19, where, and Pablo referred to it, but I have had the responsibility of kind of living with it every day, where people who live in Central Falls couldn't work from home. About 20% of people of color in the United States can work from home, which means 80% cannot. Where when we shut down in Rhode Island, we shut down many things, but we kept our factories open so that people in Central Falls basically had to go out to work every day. And when they went out to work, they got infected. And when they came home, they brought the infection into densely packed housing where 6 or 8 or sometimes 12 people would live in in a 2-bedroom apartment with 1 bathroom, and infected the entire apartment within days. And so we heard many, many stories of families or family groupings that were entirely infected. And that was one of the source of the incidence of disease that Pablo showed you. So housing and having people have equal access. Let me just tell that story in a little different way. The way to stop the chain of transmission of COVID-19 isn't testing, it's actually isolation, making sure that anyone who's infected lives or can spend at least 10 days in a room by themselves effectively and not share a bathroom. In Central Falls, that's not possible. In East Greenwich, there are a number of people who live in houses of 5 bedrooms and 3 bathrooms or 4 bathrooms with 2 or 3 people living in the house. So if somebody in East Greenwich gets COVID-19, they can isolate easily and infect no one else. But that is not the case in Central Falls. It's not the case in Woodlawn and Pawtucket, and it's not the case in South Providence. Another sort of mechanism by which structural racism works is police violence and the sort of epidemic of incarceration that has affected people of color for the last 50 years, sometimes excused by the police attempt to make a war on drugs, which turned out to be a war on Black men. That violence, I don't think I need to say much more about, as it was shown with devastating clarity during the murder of George Floyd. Another disparity is transportation, and David mentioned this and described it nicely. It is not the case that everybody has a car. 23% of people in Central Falls, 23% of family households in Central Falls don't have private transportation, which means people are dependent on public transportation, and public transportation is a wonderful opportunity to pass COVID-19 from person to person. And let me tell you, public transportation in Rhode Island is not very good at all. And so if you're trying to get to work and you have no other option, it's going to wear you out. The emotional stress of being on the downside of racism in the United States, I think, is unendless, and friends describe it. We have heard people describe it for many years. Unfortunately, too many Americans seem to hear it for the first time. But it's an unending stress, and it leads to significant physical ailments like high blood pressure and heart disease. Similarly, the opportunity for safe and healthy food is not equally distributed, and that predisposes people to obesity, diabetes, and heart disease as well. All these things together create a phenomena that is sometimes called weathering. Pablo mentioned having Dr. Jennifer Clark on his show. She's the medical director of the ACI. We have come to understand that people in prison who are 50, we count as aged because they have the same problems as 75-year-olds, because our social organization has worn their bodies down. And it is very clear that, and we learned this if we didn't know it already from COVID-19, it's very clear that that's exactly what's happened to people of color in the United States. So that the moment that this virus hit, people's bodies were worn out by living in a racist society. And that's what made them sick. And that's why we had so much of a difference in both illness and hospitalization and death from community to community. So structural racism is by far the single most significant contributor to the public health risks or the public health impact of racism. The other two pathways are, and these are painful to describe for me. The first is unequal access to healthcare. Not everybody has the same shot, not everybody has the same insurance, and not everybody has the same welcome. Many of us, Pablo and Maria and many others, have known for many years that when somebody has Medicaid in Rhode Island, they are treated completely differently when they go to get specialty care, and sometimes when they go to get primary care. When COVID started in Rhode Island, we got a number of respiratory clinics open in Rhode Island to take care of people who were sick. In the first 2 or 3 weeks, there were 4 respiratory clinics opened in East Greenwich and none in Providence, Pawtucket, or Central Falls. That is profoundly unequal access, and that let this disease spread. And finally, the other major pathway is the pathway of unequal treatment. There is also a mound of evidence. In 2002, the National Academy of Medicine published a book called Unequal Treatment, which documented in detail the differences in what medical treatments were offered for the same disease of the same severity based on race. So that things that were expensive were often denied people of color. You know, the classic story is that chronic renal failure, kidney failure, is 3 times more common in African Americans than it is in white Americans. But kidney transplant, the definitive therapy, is offered 3 times more commonly to white Americans than it is to African Americans. Help me understand that. I've been trying to understand it for 30 years. And that's why seeing and hearing the outcry to me suggests we're 150 we're 400 years late with that outcry, but boy, is it legitimate. So I think that's sort of the way I understand racism and the way I think public health can bear witness, but where bearing witness isn't enough. Bearing witness without without action is meaningless. And as I tend to say now, everybody needs to keep their eyes on the prize, but their feet on the street. And that's what I'm hoping everybody will do together, in part as a result of this afternoon. Thank you.
David, thank you. Michael, excuse me. Michael, thank you. And thank you for your passion and years of devotion to public health in Rhode Island. It's made a big difference. A number of questions, too, have been being brought up, so we'll have a robust discussion shortly. However, at this time, I'm very pleased and honored to present Dr. Marie Gazelle. Marie is a proven leader in the healthcare field, highly respected for over 45 years of dedication and service to improving healthcare and reducing health disparities for Rhode Island's most vulnerable residents. Through her accomplishments as a registered nurse, health center director, and for 11 years as CEO of the Rhode Island Free Clinic, Marie exemplifies a visionary and compassionate leader able to build strong community partnerships and strategic alliances to deliver quality healthcare for underserved communities. She leads the clinic's unique volunteer-provider community partnership model to provide healthcare for our state's uninsured, working poor, and diverse communities. Through her leadership, the clinic has expanded to provide uninsured adults with 23 specialties, including a new dental program, medications through CVS, and wellness initiatives. She serves on the board of directors for the Rhode Island Quality Institute and the Rhode Island Action Coalition for the Future of Nursing. Marie has received numerous awards and recognitions, too numerous to include now, but most recently from Bryant University's Women's Summit as Businesswoman of the Year. So I present Dr. Marie Gazelle.
Thank you. Thank you, Bob. Thank you everyone for your comments. I really enjoyed the data that was presented by Pablo and David, your comments, and Mike. Hopefully my presentation will tie a lot of what's been mentioned. I can see many similarities and hear many similarities. As many of you know, I was born and raised in Central Falls, and as I hear some of the comments now in what's happening in Central Falls, it's very near and dear to my heart. I've never been the last speaker on a Zoom call, and I also have never been through a COVID pandemic, and neither has the Rhode Island Free Clinic. So hopefully my comments will challenge us a little bit more, but it will also hopefully have each of us see what we're doing to address some of the structural racism that we know exists in the inequities in healthcare. So I'm going to share my screen. I have some slides. Just to give you a little bit of background at the Rhode Island Free Clinic. And this is great because Pablo talked a lot about where this pandemic, where COVID is affecting. And as you can see from the slides, we see about 3,000 patients at the Free Clinic, and we basically serve 85% of the Latino and Black community. If you compare our numbers nationally to uninsured, statewide, and also from national data, you will see that we serve above the national and the state averages for the Latinx population and also for the Black population. And we serve a very low number of the white population. Right now, we're seeing a majority of females at the clinic, and as you can see from where we serve, majority of our patients are from the Providence area, although we do reach Central Falls and Pawtucket, a high segment from that area as well. Just to tell you a little bit about what we do at the Rhode Island Free Clinic. We're a medical home for this population that really is forgotten. We focus on providing quality primary care, specialty care, labs, testing, medicines, due to the generosity of CVS Health. We provide minute clinic after hour cares for our patients. A year and a half ago, we added a dental program, which was probably the only dental program for uninsured adults that opened up in our state. We provide on-site behavioral health care. We are providing telehealth services now because of the COVID-19 pandemic. And about a month and a half ago, we opened up a COVID testing site at our premises, a drive-through and a walk-through. And we focus on outreach and a lot of patient navigation. All of our services are free. More than 50% of our staff is bilingual, and all of our frontline staff is bilingual. And we focus on, we're really the first avenue of care for many people that have never received health care. So I wanted to talk a little bit about why do the patients need the Rhode Island Free Clinic? And this really talks a lot about social determinants of health, which I know many of you are very familiar with. And really, many of the comments that many of the panelists talked about for the Black and Latino population that we're seeing at the Rhode Island Free Clinic, we know that our patients are poor. Currently, 65% are below 100% of the poverty guidelines, and since the pandemic occurred, we're seeing people just don't have any money. I think they, that number we know is much higher. As Dr. Fine talked about access to services, if the clinic didn't exist, many of the people we see would not get any health care. We're seeing very sick people that come in with chronic conditions, diabetes, cardiac disease, and we're able to provide the services to help them. I've talked about the race, the age, and the gender of our population. As I said, we're really here for this community, and will continue to be here. The past year, we've also been seeing more older women that have been left out of care. And interestingly, 15% of our population is over 65 years of age, and they don't have access to any benefits in the state. And if the clinic didn't exist, these are people that also would not have any care. We pride ourselves with serving the entire state, but as you can see, we primarily serve the urban core. Our patients are limited by transportation, and I know Dr. Fine spoke about that barrier, which is a significant barrier for the patients that we see. We work with that to help patients. Housing and food insecurities are priorities, and now more than ever through the pandemic, they're major barriers for our patients. I'm very glad that we spoke about the service industries. Our patients work. They work as cleaning people in the hotels. They work in factories. They don't want to lose their jobs. They do not want to, they live in tenements, as Mike mentioned earlier as well. So this is exactly the population that we see at the Rhode Island Free Clinic. Social support and safety. Our patients probably don't have as much support that some of us take for granted with our families. And right now there's been so much anxiety, depression that has affected the population that all of our patients immediately, they see a behavioral health counselor at their first visit. There's so much anxiety that has been created, and they're also very fearful, as has been mentioned during this conference, about their safety. whether they are an immigrant or whether they live or know of people, family members, there's major concern about their safety. So what are we doing at the Rhode Island Free Clinic? And I think this is probably the most important slide, and I hope will tie together a lot of what's been said during this conference, is, you know, as a nurse, I was basically, you know, I worked and felt throughout my career that everyone deserved health care, and what I got, everyone should get the same. And as has been mentioned, that's not the same for everyone. Everyone should receive the same quality of treatment, whether you have insurance, whether you don't have insurance. At the Rhode Island Free Clinic, it doesn't matter. Everyone's uninsured, and everyone has access to the same level and the same quality of treatment. And we have some of the best physicians, including Dr. Naparzik, who is our MC here for the day, that provide care. So we have the highest quality of care for our patients. And I think that's a very important issue, that everyone is treated the same. I don't know what's happened in our healthcare system, but I've been around a long time. And over the years, I've seen that there's been so much structural barriers for people, racism, inequities, and I am very blessed to be working at a clinic where there are no economic barriers for services. All our patients get medicines, they get labs, they have access to bilingual, bicultural staff. And, you know, I wanted to mention about our COVID testing site. We decided to open up a site because there really wasn't a site opened up for anyone who was uninsured, for anyone in the Providence area who did not have a doctor, who did not have, you know, have access. And as has been mentioned throughout this conference, we need to get to the people that needed the care. So we opened up a testing site for everyone. And if you weren't a patient of the free clinic, we would still see you, and we brought those people on as patients. So to date, we have a testing rate of about 22%, and we're seeing over 50% of the people coming to our site are not patients of the free clinic, but have become patients of the free clinic. So as we challenge ourselves after today to look at what we should be doing, we all should be doing more, because we're not doing enough right now to help the community and to help the people that, you know I see at the free clinic and that are out there and are still afraid and are still not getting the testing and the care that they need. I wanted to, the last really point, and I think it's extremely important, is that there has to be community trust. And that's one, I think, important component that the Rhode Island Free Clinic brings, is the trust that when the patients come here, they trust that we care about them. It's all about the mission. It's all about taking care of people. There are no other barriers here. It's just trust. And I think people sense that when they come into the clinic and they see how they're treated and the facility itself. They feel safe, and most importantly, that they feel there's dignity. And I think as we end, and as I end my comments, I did want to emphasize that those are probably three of the most important points I see that we all need to do a better job with the inequities and the structural racism that exists. Is we should develop in all of the healthcare system. We all need to do better. And I'm just very proud of the volunteers and the staff that I work with for what we're able to do for the population that we see. So thank you everyone for being able to participate in this conference, and feel free to reach out to me, any of the participants, if there's anything that I can help with or any further questions that you have of me. Thank you.
Thanks, Marie, and thanks for all your work at the Free Clinic. To everyone participating, Marie is being very humble. She's just a dynamo at the clinic and makes the place what it is. We have 20 or so minutes for the Q&A, so I want to go right into it and do a little bit of a rapid fire, so if everyone can keep their responses short. The first question is what just came in recently from Todd. That almost seems like a plant that Marie may have set up. I'm joking. But Todd asks, where does the Rhode Island Free Clinic get its funding? How can we help?
Great question. Robert, did you want to answer that since you know us very well?
No, I would defer to you. I'm the moderator.
We're 100% philanthropic. Unlike other clinics and unlike a community health center, we receive no federal dollars and we bill for no services. So we rely 100% on philanthropy and the generosity of partners like Lifespan, like CVS, Amica, many of these companies that contribute. But a big part of my job is really trying to develop more partnerships and having others share my passion that everyone deserves healthcare. So it's all philanthropic.
Yeah. Can you speak to also to how much money it costs to support a patient?
So for $500 a year, we can provide healthcare, quality healthcare for an adult. And as I mentioned, we also opened a dental clinic a year and a half ago, and that now includes dental. And that includes everything. That includes their medicines, that includes testing, that includes physical therapy, that includes diabetes education. So that's a very small amount of money to ensure that someone who would otherwise be lost would be lost to any healthcare.
A question came in from, Aronel Hart for David. Why is this moment, this more than just other hashtags, why did this moment with George Floyd's murder feels different? Is something more happening than other incidents that come and go in the news? David, you want to take that? Is this different, or is it what we all worried is maybe becoming lip service?
Yeah, you saw, with your guidance there, Robert, I'll try to be fairly quick in my response, but this is my opinion. I think there are a lot of reasons why this time is different. Somebody asked me if I think racism is worse now than it's ever been, and I don't believe that. What I believe is that racism is being captured on iPhones and being posted on social media now. Again, this stuff has been happening for a long time, but think about how many other George Floyds there were that nobody was around with an iPhone to capture, right? So I think one of the things that really made this moment feel different is the proximity of Ahmaud Arbery, Breonna Taylor, Christian Cooper in Central Park, and then George Floyd right on the heels. That was all within a span of 30 days. Mm-hmm. And I think even the Central Park incident felt a little bit differently because you heard Amy Cooper admit verbally that she was calling the police because she knew she could weaponize Mr. Cooper's skin during a police encounter. I think, there was a lot of intuition around people doing that, but she verbally said it during her call. So I think, and then you got COVID-19 as a layer on top of all of that and the tensions that people were already feeling dealing with the global pandemic and the disparities that we've talked about from the pandemic. So I think if you take all that, we really created a perfect storm for this to feel different than I think it's felt before. And I'm going to remain guardedly optimistic that we're at a turning point of really moving forward in a real and meaningful way, more so than we have over the past couple of decades.
Sure. Anyone else want to comment on that? Michael, any thoughts about, is this different? Because you worried about lip service.
I think it will get different if people keep their feet on the street. I mean, I think there's a moment of opening, but the dominant culture is very powerful and tends to revert. Somebody, I can't remember whether it was David or Pablo, said something about, sort of how movements get swallowed up and diverted. And I think that will happen to this one too, unless people stay engaged and make it happen. Democracy is something we recreate every day. And we will lose this democracy if we don't keep it alive by standing up.
Sure. I worry that we attendees at this conference are people, like-minded people in general, and that we may be preaching to the choir in a way, but that it's up to us to really spread this out, especially to those who might disagree with the content of this conference. You know, that's our task.
Robert, if I could add to this, you know, in terms of racism, all you need to do is ask any person of color if you ever had a suspicious encounter with the police. And I know I have. I know I've been stopped simply because I was driving a brand new car, and I was not supposed to drive a brand new car when I had my afro when I was younger. You know, what is happening now, I think, is that, and this is a factor of leadership, you know, we have to admit that the Trump administration, the president of the United States, have given permission for people to be overtly racists. So now we're not only seeing the effects of racism in health, the effects of racism in the lives of people, but the normalization of, you know, being overly racist and seeming to have no consequences.
Yeah, a very important point. In fact, a question came up about Donald Trump, Pablo, while you were speaking, from Crystal Swepson from Maine, who asks that she'd like a comment about Trump saying that 99% of cases are harmless, and that she has a friend in Maine who believes it. But because it came up during your talk, I wonder if you'd comment on that.
It's completely, you know, garbage. You know, he has no reference. He pulled it out of, you know, another part of his body, not out of his brain.
Sure, sure.
No, I actually have some data. So of cases, remember, there's a difference between cases and infections, but of cases, about 10% require hospitalization, and likely a third of those may be fatal. So the 1% number is measurably not true. Public health creates accountability.
Yeah. Speaking of public health, Michael, another good segue. There was a question, from Richard Rodriguez about getting food to communities of color through mutual aid networks. Good nutrition is one of the pre-existing conditions. A lack of good nutrition is a pre-existing condition, especially in children. You mentioned about the basic public health parameters of infant mortality, et cetera. Can you speak to that about the state of nutrition during the coronavirus pandemic?
Well, I can speak to this, that as soon as we closed the schools, people who run schools started working hard on delivering meals. Mm-hmm. And all of a sudden I learned that some huge proportion of American kids needed those meals to survive. That we have come to the place in the United States where many of our families can't feed their children. So that's one thing to reflect on. The other thing to reflect on is, you know, we have let food like healthcare, we've turned food like healthcare over to the market. The market is good for some things. It's great for television sets, great for you know, selling lipstick, I guess. But it's not good for healthcare. It's not an effective way to distribute healthcare, as we have seen. And it's probably not an effective way to distribute food. You know, there are state stores for alcohol in New Hampshire. Seems to me we ought to have state stores for fresh and healthy food in every community in the United States.
Good point. Pablo, have you seen that in the Latina, Latinx community, especially in children?
In children and in families, especially in undocumented households that have no access to any of the benefits of food stamps, of unemployment, of TDI, or any of the benefits. There's definitely been a food insecurity. In Rhode Island, we have a group called the Elisha Foundation that has done an incredible job at distributing thousands of meals to households, because the children were still able to get, if they were getting food in school, the distribution system was able to bring that food to them. But the undocumented households do not have access to that to that food. So the Elisha Foundation has been able to be distributing many meals. In the United States, there are about 2.9 million students that depend on those meals just for their only meal.
Yes. Maybe a final question now in the few minutes we have left. Sandra Haynes Murdaco, I hope I'm pronouncing that correctly, said that she couldn't help, in listening to our panelists, acknowledge the atrocities against Native Americans. And she asks, where do they fit into these conversations? David, you want to take that?
Yeah, I will take that. And I'll tell you, I think she is exactly right. I don't know that I have much more to add to that comment than the fact that she is exactly right. It's something on my radar screen as a diversity practitioner. I will tell you, one of the things that frustrates me the most about trying to figure out how to best help the Native American community is the lack of freaking data. You know, trying to get good data, even with COVID-19, the lack of good data. I think we know that we have some data, and it's not a pretty story. But I think if we can get more data for that community in general, I think it will be helpful. But I'm with you. I can't say that I have more to add. It is a part of our diversity strategy at CVS Health. So we have a 4-part strategy. One is bringing talent into the organization. The second is making sure we have a company culture where people can bring all of who they are to work. The third is ensuring that everybody can grow and develop. And the fourth is meeting the needs of our communities and all the people we serve externally. So they are part of that strategy. We even have an employee group focused on the Native American community. But I'll tell you what, just more generally speaking, I could not be more saddened, frustrated, and angry about the lack of discourse about what happens to the Native American community. Not to make this political, because I am not authorized to make political statements on behalf of my company, but I will say, from the general public, seeing people yelling at Native Americans to go home in front of Mount Rushmore is the most imbecilic thing I could have ever seen. You know, they're asking to be invited to the table. They should be inviting us to the table. I'm going to get off my soapbox, but just to say I agree with you. We need to make sure the Native Americans are part of this dialogue.
Sure. No, I appreciate that. At the Center for Reconciliation, we specifically use the word genocide and look ultimately, as in slavery, for apology and reparation.
So Robert, for Native Americans, the COVID-specific epidemic has been more of an economic crisis because most of the tribes have lost almost 100% of their taxable income. 40% depend on casinos, tourism, all the businesses that are in Native American reservations have been just decimated. In terms of COVID, they have not been hit as hard simply because they've been able to isolate, to be able to practice, social distancing from the people that have the virus. And the last numbers that I saw were about 4,000 positive COVID patients in the entire nation that are listed as Native Americans. In terms of data, all data is absolutely lacking. When you look at the data from the CDC, the data from the health departments, only 50, in a good day, they get 60% of demographic data for people, which is just absolutely atrocious. I mean, they can get everything except the race and ethnicity, in the forms. I always find that absolutely, amazing that in this country, we still cannot, be able to just identify people by their race and ethnicity in all the official statistics.
Yeah. Well, thank you. The clock is ticking, unfortunately, and at this point, I very much want to thank our panelists for a passionate, provocative, and super important discussion. With a very few minutes remaining, I want to introduce our CEO and Executive Director, Deborah Sharp, who is, just fantastic. She'll be saying a few words, and I also want to thank Julia Renaud for her technical help, moral support, and all around cheerleading all of us to get to this point. So thank you. So I'll pass the baton to Deborah.
Thank you, Robert. Wow. First of all, I want to thank you all for participating in the webinar this afternoon. A special thank you to Dr. Parsnick as our moderator and to our brilliant panelists. It was so interesting and so informational, and I want to thank you from the bottom of my heart for sharing your insights with us. And secondly, I want to thank all of you for being here, because I see so many friends of the CFR. I see the wonderful Mr. Delbert Glover, one of our original founding members, and my beloved predecessor, Linda Grins, who was the first executive director. I also want to thank the team at the diocese. As you sure know, it takes more than 1 or 2 or 3 people to pull something like this together. So thank you to our bishop, the Right Reverend Nicholas Knisley, Canon Dina Cleaver Bartholomew, Marianne Mello, Kristen Knudsen-Groh, everyone who pulled together to put this wonderful program, make it available to everyone, and especially to the CFR's outstanding exhibition manager and curator, Julia Renaud, who magically makes things happen. So thank you all. And thank you for your interest and your support. I want to let everybody know that in the next couple of weeks, we'll be sending out a survey. We'd love to have you share your feedback with us. If you have ideas that you'd like to share for future programs, please feel free to include those in your notes. We appreciate your insights and your sharing how you're feeling about this. And now for the commercial announcement that I must make. If you enjoyed the program and found it informative, and if you're looking forward to participating in more of our programs and events at the center, we would ask that you please consider making a donation to our work. The mission of the center is to foster racial reconciliation and racial justice by confronting the legacy of slavery. And we as a nonprofit organization receive no state or federal funding. So much like many other nonprofits doing work in the community, we rely on the generosity of donors, our corporate partners, and people who support our mission. So please consider making a donation if you can. We appreciate this. We try to keep all of our programs free of charge so everyone can participate. So thank you for your consideration in that. And lastly, I'd just like to encourage you to visit our website, www.cfrri.org. Sign up for our newsletter, follow us social media. Please participate with us. We look forward to presenting another program that I think you're going to find interesting. We've tossed around some ideas, but our goal is to every 4 to 6 weeks have some kind of a virtual offering for you so we can all stay in touch with each other. So thank you to our old friends. Thank you and welcome to our new friends. Thank you to our brilliant panelists. We are so appreciative of all you do to support our work. So everyone, thanks and have a good evening.
Thank you.
Thank you all. The conference is hereby adjourned, and we really appreciate your being with us and your attention. Thank you again to all the panelists.
Yes, thanks.
All right.
Thank you.
Best wishes to everyone.
Yep.
Bye-bye.
Bye-bye.
Bye.